If you want to master resuscitation as a team leader or a team member, this video is for you. It's a talk I gave that covers many tips on resuscitation and the superpower of human influence and persuasion. There is so much packed into this that there's something for all resuscitationists, and you can check out the description for links to references if you want to read more into this fascinating area. I gave this talk way back in 2013, and I still apply every single one of these concepts in my practice today as I strive towards resuscitation mastery. Let's go.
Thank you. Now, you all know how to resuscitate already. You've all done your life support courses. I bet some of you have been nominated to be an ATLS instructor, you trauma badass. But then, bang, you go to a scene like this, and you're confronted with an explosion of noise and smell and light and fear that pervades all corners of your senses. And all that study and training and experience gushes out of your anus as you struggle to see through the fog of cognitive overload and emotional distraction. How can you get on top of that stuff and get control? Now, these are pre-hospital scenes, but this stuff still applies in the ED or the ICU. So I want to give you some tips on how to make things happen. Now, it's important to get control of 4 domains: yourself, the environment, the team, and the patient. And if you lose control of one or more of these things, it results in an increasing level of pain for everybody. It can be a real problem. We don't want to get to that right-hand side. So we're going to do a clinical scenario. I want to imagine you're working in an emergency department of a small hospital. It is not a trauma center. Going straight to the operating room for a trauma patient to be dealt with by a trauma surgeon is not going to be an option for you. And this is happening pre-hospital. So this guy's agitated and combative. He's been stabbed in the chest. He's a 19-year-old male, and he's got abnormal vital signs. The paramedics cannot get control of him, so they're bringing him into the nearest hospital where you're working. It's going to get busy. People are arriving. Your team leader, some of these people are big. They have big personalities and big egos, and we really need to be able to control them to make things happen. So our team leader, this is you, needs to be able to get into the right mental space to access a performance state. You have to use metacognition and mindfulness to be aware of and to be able to control your thoughts and your emotions so that you can be calm and focused and confident. You have to be in control of your posture and your breathing. I mean, even how you stand is important. No one is going to follow this team leader. They're going to ignore her. But this one has presence. So she's making eye contact. She's even labeled team leader. She has the attention of her team, of her audience. In keeping with what's known about effective resuscitation teams, she will allocate tasks before the patient comes in. And she's going to get control of the environment. This is a cluttered resus room. This is no good. Things you don't need to go. If you have movable partitions, you can expand the size of the bay because you need 360 degrees of access if you want to manage the patient properly. This is going to be shambolic and inefficient and dangerous when someone gets a Sharps injury. So let's set the resus room up properly. We can pretty much anticipate what interventions this patient's going to need, so why not get the equipment ready? There's blood up going through a blood warmer. There's a video laryngoscope. RSI drugs are drawn up. The capnograph is checked and calibrated. The ultrasound machine is even switched on and pre-gelled and by the bedside. And the thoracotomy tray is out and checked, so people are getting their heads in the right space for what may or may not be happening in the near future. Okay, so imagine you are a nurse or a doctor from another service that's been invited to come and participate in this resuscitation, and you get there, and the leader politely and assertively introduces herself to you, tells you what the plan is, anticipates some clinical outcomes, tells you what equipment is ready for that, and what she would like you to do. It's going to be very hard for you to challenge the momentum of confidence that people have. You won't want to sabotage that. There's already a trajectory going on here, and you're going to fit in. So make the most of that. If you're the team leader, there's an important principle here that credibility and authority and being liked are really powerful persuasion tools. Perhaps the most important message here on how to make things happen is how you carry and convey your message. Okay. The patient comes in. He's fighting. He's uncooperative. He's declining your generous offer of oxygen and IV access and monitoring. The 3 tethers to the resus bed that all sick patients must have, these mooring lines that I want to see all patients attached to so I know they're not going to float away. How do we get control of him? Well, with rapid 5-point physical restraint, just in sufficient duration to deliver some ketamine, intramuscularly if there's no line-in. But this is an important rule of thumb or heuristic in resuscitation. There are certain clinical scenarios that lend us to make a split-second decision. This will work in this situation. Let's do it. And using these rules of thumbs, of course, can get you into trouble, rarely, but most of the time, for critical situations, they can be very, very helpful because they remove the cognitive load associated with deliberation and problem solving when you don't have time for that. So here's another principle. Get control of a flailing, agitated trauma patient. Ketamine is the most reliable way. Another general rule of thumb I use, particularly pre-hospital, is a flailing, agitated trauma patient is going to end up getting intubated. All right? The so-called gagging for the blue cigar. So the question is how we get that blue cigar in his mouth safely, and we need to dissociate him with the sedation first so that we can set up for a safe RSI. So he's flattened now with some IM ketamine. We've got some vital signs. We can do an effective primary survey, attach oxygen, get vascular access, get our monitoring on. We can set up for RSI. Now, someone in the team says, this is really urgent. He's really sick. I don't think we should use the normal checklist we use. Let's just crack on and get this tube in. This is important. Bad thinking. This is not the time to compromise your safety. So another important principle, if you have safety checklists, if you have systems, they are required more in the urgent situation rather than less. This is not the time to cut corners. This is the patient who's going to arrest on induction if you don't look after adequate pre-oxygenation and apneic oxygenation. Get the position right for first pass success. Get the monitoring ready so your capnograph is good to go. And choose the right induction agent, which isn't this one. So this is controversial. The tweets, I can actually feel them hitting me in the head here now. But I'm using this platform as a soapbox to say high doses of propofol will execute sick patients who are hemodynamically compromised. All right? High doses of propofol. I'm not saying it's a bad drug. I'm saying the way it's used time and again, it's probably happening at this moment, certainly around in Australia and Britain, as patients are being put into cardiac arrest who are hemodynamically unstable because propofol is the drug of choice for the emergency physician. And I don't understand why, because we have such a great alternative with such a great name. Rock and ketamine, okay? Ketamine and rock is my go-to stuff for a rapid RSI for the vast majority of patients that I deal with in critical care and pre-hospital care. Now, there are exceptions to that, but again, as a rule of thumb, you're going to get this in quickly, and it's going to work. I mean, propofol still has its proponents. I remember when I was training a new group of registrars for the retrieval service, and I was going on and on and on about this, and said, as far as I'm concerned, propofol as an induction agent for the hemodynamically unstable, critically ill patient is like delivering the semen of the devil to the patient. And immediately, one of the registrars retorted, well, as an anesthetist, I love propofol, and I consider it to be the milk of lactating angels. Okay, so we're doing our checklist, we're getting ready to do an RSI, and then a bright spark in the audience, a keen team member says, I really think we need to do a chest x-ray first. If there's a pneumothoracic contention, we might need to put an intercostal catheter in. So there's an issue here, and that is that most people will be subscribing to the generally accepted resuscitation algorithms, the trauma paradigms that are widespread and are safe for junior people. But you're in kind of a different mode. You're not in ATLS mode here as the team leader, okay? You're not going to be going through the ATLS algorithm in sequence. You are not process-driven. You are more outcome-driven. You are in a let's keep him alive mindset. And you're going to be using simultaneous activity, getting your team to effect interventions in parallel to get to your endpoints of alleviating hypovolemia, tamponade, and tension pneumothorax in this stab victim. You don't need the fingers and tubes. You don't need the plain radiography. You accept that sonography is going to answer the questions that you're asking much better than plain radiography. There's potentially no role for plain radiography in the resus room in this patient. So we're going to omit that completely. We're going to intubate this patient because he needs it, so we will set up for an open thoracostomy rather than the delays that will ensue if we put in local anesthesia, put in a chest tube, connect it to a closed drainage system. So we are deviating from protocol. But in some simulation studies, that has been shown to be a marker of effective resuscitation teams. There are other obstacles. So sticking to the basic trauma paradigms or basic resuscitation paradigms is one obstacle. Another one are cultural habits. Certainly in Britain and Australia, how do we allocate roles within the trauma team? The most difficult intervention, putting a big IV line in a shut-down vein in a sick trauma patient, we allocate that to the most junior member of the team, in my experience. We get the internal junior house officer to do it. The IV access is critical to delivering analgesia, to establishing a secure airway through RSI, to giving hemostatic resuscitation. We can't do anything in trauma until we've got IV or IO access. So giving it to the most junior member of the team is insane. Why do we do it? They invariably have 2 or 3 goes, and it puts a pause on the proceedings. They need to learn, but maybe not on these kinds of patients. So that's another potential obstacle we need to overcome. In our minds, we do the best thing for the patient. And we all subscribe to the idea of first pass success for laryngoscopy. But I think we should be looking at first attempt success for all of our critical procedures, including IV access. Okay, so we've got him intubated. We've got good IV lines. We've got blood hanging. The surgeon isn't here yet. Sonographically, we've identified a left-sided pneumothorax, so we're doing an open thoracostomy. There's a hiss of air. There's a brief period of hemodynamic improvement. This patient has got a little bit better. There's a collective sigh of relief around the room. We've all seen this. And this is a dangerous period. And as team leaders, you need to watch out for this. So there's a little bit of humor in the banter now, and someone wants to review the ultrasound images for their own education. Someone's getting ready to put a bladder catheter in. The nurse in charge asks you if you'll be going to the ED Christmas party this year. And there's gradually an increasing level of frivolity in the room that is bordering on the inappropriate now. Now, I've seen this happen time and again after intubation. If someone struggled to get the tube in, once it's in, collective sigh of relief, that's great. Guys, how about squeezing the bag now? Forgetting to bag, forgetting to give the analgesia, and sedation is an issue. So as team leader, you mustn't lose your situational awareness, because things will run away of their own accord if someone doesn't have their eyes on the patient and on the monitor. So I think resuscitation rooms have a natural tendency to go from a state of order to disorder. In thermodynamics, this is entropy, isn't it? And I think there is a concept of resuscitation room thermodynamics. In any resus, there's a natural progression towards disorder and chaos, which requires significant positive energy or effort to prevent or reverse. It's an active process. And if you stand back, if you're joining in the collective sigh of relief, things will get out of control. But it's hard, because each major cognitive task you undertake takes its toll and makes it harder to do the next one. So there will be an element of fatigue. All right. But we're doing well. We have identified this patient is getting sicker now. He's losing his output. And we've identified a pericardial effusion with tamponade physiology on ultrasound. It's easy. There's only one course of action now. Unfortunately, the surgical registrar, a fairly junior doctor for the surgery team, has arrived. Go, Carl. So, yes, Carl, the surgical doctor here, he is not happy. He says, it's not a trauma center. We're not going to do thoracotomies. You should do pericardiocentesis. That's in the guidelines. Furthermore, he's not happy with your thoracostomies. What the hell are these holes? Where are the chest tubes? Where are the chest drains? And we've got a couple of issues going on here. We don't really need this right now, but we have to understand what's going on to be able to deal with it. So he's been late to the party. All this effort we put in to convincing people of our effective leadership and getting the whole team on the same page carries no sway with someone who's just arrived. We're starting afresh. And the fact that he's choosing interventions that he's comfortable with and he's being critical of your management is diagnostic of a cognitive emergency reaction. It essentially means he's out of his depth. People try and claw back their feeling of control by being critical, by being overly aggressive, and by seeking out information that will confirm a particular state that's reassuring to them. More important to him now than the outcome for the patient is the feeling that there is no problem for the patient, that this is all under control. So we need to understand that before we can deal with it. And we need to avoid any antagonism to make it worse, because we'll get nowhere. We've got to bring him on board, which brings us onto the science of human influence and persuasion. We have to rapidly gain compliance from this colleague, or things aren't going to happen for this patient. Now, the social psychology literature is replete with some fascinating stuff, but I make no guarantee that it will always work in the particular peculiar setting of a critical resuscitation. Some of it, many of us have tried and have found it effective some of the time, but of course there's no guarantees that you can extrapolate stuff done in the psychology laboratory or in field experiments to our particular situation. But let's go through some of the principles. It's really important how you appear, what you do, what you say, and how you say it. Now let's take some examples. The first rule of all is be nice. I mentioned this before. If people like you, they will want to do things for you. If people like you, they will want to do things for you. This is so important. And if you do something nice for someone, they will want to reciprocate. So these are the principles of liking and reciprocity. Be authoritative, though. We mentioned this before about projecting your leadership qualities, inspiring confidence in the team. And there are studies on this in the simulation setting, showing that resuscitation leaders with a more directive leadership approach get more done and provide more effective resuscitations than those who are more collaborative or empowering. But this is particularly true the sicker the patient is. Always stay patient-focused. So don't get drawn into an argument about things, particularly if it becomes personal or it's peripheral to the immediate clinical needs of the patient. State the facts that pertain to the patient and what the patient needs. That won't just enhance the strength of your message, it will make the recipient much more receptive to your message. And ask for help. Now, in some ways, this might seem like it contradicts the authoritativeness advice, but it doesn't really. If you ask someone for their help and get them on board and get a small favor out of them, they're more inclined to give you a bigger favor afterwards. These are the concepts of consistency and of commitment. So you can politely ask for help without being submissive. And use the group. It's not, well, actually, that might work too. But not a grope. A light touch on the arm has been shown to influence someone when you're asking a favor. A gentle touch on the upper arm has been shown to be an effective persuasive technique. But yeah, that's not a grope. But use the group. It's not me versus you. It's our team are inviting you to help us. This is the social proof concept. Very hard for someone to go against the will of the rest of the group. So we need your help with X. Our plan is Y. That's very powerful. Okay? And push the right buttons. I'm very keen that Resus team leaders keep stating their mental model of what they think is going on and sharing that with the patient so you can agree the goals and maintain the mission trajectory. But sometimes that mental model is not getting across. There's something about the intentions or beliefs or attitudes of the recipient that it's just not clicking with. So let's take a concrete example. You want the patient intubated. The doctor at the head end does not think they need to be intubated. You want it to happen so you can progress the resuscitation. He doesn't want to do it because he's happy that the patient's maintaining their protective airway reflexes. You're kind of both right, but you're arguing about the wrong thing. So we need to reframe it, push a different button. For example is, from a neuroprotection point of view, are you happy with this PCO2? It's pushing a different button and might trigger them to intubate. Even more powerfully, we would like your help improving this patient's ventilation and getting on top of this CO2. You can see how many different buttons that's pressing. And craft your language carefully, dare I say sneakily. Presuppositions are quite powerful. So this is when you embed a preconceived idea into a sentence as fact. so the recipient assumes it to be true and doesn't question it. I'll give you an example. Compare this when you're trying to get a patient admitted. Doctor, would you like to come and see Mr. Wallace? Versus, Doctor, will you be seeing Mr. Wallace on the ward or in the emergency department? That's also known as a double bind. That presupposition is powerful because it presupposes they're going to be seeing the patient. It also gives them the illusion of choice, but you don't mind which outcome they agree to. It's fascinating stuff. There's a great experiment. I mean, this can even create false memories. It's a fantastic experiment where subjects were asked to watch a video of a road traffic crash. And then they were asked a question phrased in two different ways. Did you see the broken headlamp? Versus, did you see a broken headlamp? So the people who were asked, did you see the broken headlamp, had a much greater rate of, yes, I saw it. But the really cool thing about this is in half the videos there was no broken headlamp. But if you were asked, did you see the broken headlamp, you actually remembered seeing it. So presupposition is very powerful. Hypnotists use it all the time. You allow yourself to notice how heavy your eyelids are getting. Sorry, wake up. Wake up. So we're going to use some of this stuff. Sadly, a really important thing as well, according to the literature, is it really helps if you are attractive, if the recipients to your message find you physically attractive. But I can see that's going to stretch the limits of feasibility here, so we won't dwell on that too much. But ultimately, it doesn't matter if that's not working. As team leader, you have to make a decision. This patient needs the resuscitative thoracotomy. You need to make it happen. This isn't the time to be looking up the indications. This is also not the time to be weighing up the implications, the pros and cons of doing it. You have to have made those decisions in the past so you can access that rapidly when the situation has arisen that demands this action. So the decision was made in the past, there's a call to action, you do it, and you have a crystal clear image in your mind of that clinical goal, of that endpoint, and you do not stop until you achieve it. And you manage that in this case. Congratulations. There's tamponade, which you relieve. There's a single right ventricular wound, which you staple. The patient has a fairly straightforward and rapid postoperative course. He's discharged, neurologically intact, and within a fortnight, he's back outside selling illicit drugs to school children. Well done. Go team. Good work. So how did we make that happen? We controlled these 4 domains. With ourselves, we accessed the right performance state of mind. We allocated tasks to our team. We prepared our resus room. We got rapid control with ketamine so we could do a safe RSI using our checklist. We used a safe choice of dose and agent. We had an outcome-driven approach to his resuscitation, motivated by rapidly identifying and treating the life-threatening things, but acting in parallel, with simultaneous activity rather than series. And where necessary, deviating from standard guidelines to get the right thing done from the patient. We put our best guy on the job for IV access because that's so critically important. We didn't do any x-rays. We did ultrasound. We didn't put a chest tube in. We did an open thoracostomy. We had controlled frivolity. We had a good time. We didn't let it get out of hand, so we avoided excess entropy. We diagnosed our colleague's cognitive emergency reaction, and we brought him on board using our human persuasion and influencing and compliance gaining techniques. And we realized how important it is how we conduct ourselves and how our verbal communication is so critical. And we used a number of tips that I've gone through, your SMACC tips that you can take away and work on. I will put the references to that literature on the resus.me website. But your job is to go away and try and make this work. Your job is to be ready for these situations, to think about these things, so you can go out there and you can make it happen. Thank you.